Hello and welcome. Today we're diving into a complex and often overlooked connection: interstitial lung disease, or ILD, associated with primary immunodeficiencies, sometimes abbreviated as PIDs. We'll explore what this means, why it happens, and what can be done about it. Let's begin. Primary immunodeficiencies, as the name suggests, are genetic disorders where parts of the immune system don't function properly. This makes individuals more susceptible to infections, but it can also lead to other complications, including ILD. The exact causes of ILD and PDs are multifaceted. Sometimes recurrent lung infections trigger inflammation and scarring. In other instances, the faulty immune system itself mistakenly attacks the lung tissue, leading to damage. Certain genetic defects directly impact lung development or function, making individuals predisposed to ILD. The pathophysiology of ILD and PEDs is a cascade of events. First, the compromised immune system fails to effectively clear pathogens or regulate inflammation. This chronic inflammation causes damage to the alveoli, the tiny air sacs in the lungs responsible for gas exchange. Over time, this damage leads to fibrosis, or scarring, of the lung tissue. The scarred tissue thickens and stiffens the lungs, making it harder to breathe and reducing the lung's ability to transfer oxygen into the bloodstream. Unfortunately, precise epidemiological data on ILD specifically related to PIDs is limited. Because both PDs and ILD are individually relatively rare, the overlap is even less common and therefore more challenging to track. However, we know that ILD is a significant cause of morbidity and mortality in individuals with certain PIDs. Prevalence estimates vary based on the specific type of PID involved, but it's important to consider ILD as a potential complication in any patient diagnosed with a PID. The signs and symptoms of ILD in PEDs can be varied but often include a persistent dry cough, shortness of breath, especially with exertion, fatigue, and sometimes chest pain. You may also notice rapid or shallow breathing. Over time, clubbing of the fingers, a widening and rounding of the fingertips can develop. Because the symptoms of ILD can resemble other respiratory conditions, it's crucial to consider underlying immunodeficiencies in patients with unexplained lung disease, especially in those with a history of recurrent infections. Diagnosing ILD in the context of a PID requires a comprehensive approach. This starts with a thorough medical history, including details about recurrent infections and family history of immune disorders or lung disease. A physical exam will assess lung sounds and overall health. Pulmonary function tests like spirometry measure lung capacity and airflow. High-resolution computed tomography, or HCT scans, provide detailed images of the lungs, revealing patterns of inflammation and fibrosis. In some cases, a lung biopsy may be necessary to examine lung tissue under a microscope to confirm the diagnosis and identify the specific type of ILD. While ILD itself isn't a single disease, there are several different patterns of ILD that can occur in association with PIDs. Some of the more common patterns include usual interstitial pneumonia of IP, nonspecific interstitial pneumonia, an SIP, lymphoid interstitial pneumonia LIP, and granulomatous lung disease. The specific type of ILD can sometimes suggest a particular underlying PID or influence treatment decisions. Treatment for ILD and PDs is multifaceted and aims to control inflammation, manage symptoms, and prevent further lung damage. This often involves a combination of approaches. Immunoglobulin replacement therapy, which provides the missing antibodies, can help prevent infections. Anti-inflammatory medications such as corticosteroids or other immunosuppressants may be used to reduce lung inflammation. Supportive care, including oxygen therapy and pulmonary rehabilitation, helps manage symptoms and improve quality of life. In severe cases, a lung transplant may be considered. Unfortunately, there isn't a direct way to prevent ILD from developing in individuals with PIDs. However, proactive management of the underlying immunodeficiency is key. This includes adhering to prescribed treatments, such as immunoglobulin replacement therapy and prophylactic antibiotics, to prevent infections. Regular monitoring for signs and symptoms of lung disease is also crucial for early detection and intervention. Vaccination against common respiratory infections can also help to reduce the risk. The prognosis for ILD and PIDs varies greatly depending on the specific type of PID, the severity of the lung disease, and the individual's response to treatment. Some individuals may experience slow progression of the disease and maintain a reasonable quality of life with appropriate management. Others may face a more rapid decline in lung function. Current research is focused on better understanding the mechanisms driving ILD and PDs and developing targeted therapies to reduce inflammation and prevent fibrosis. Gene therapy holds future promise for correcting the underlying genetic defects in some PIDs, potentially preventing ILD altogether. While a diagnosis of ILD and a PD can be daunting, ongoing advancements in research and treatment are offering hope for improved outcomes.